This is Emma, I'm just
I'm Andrew, I'm the nurse on duty today. This gentleman was just being brought in by the paramedics.
Hi, you good afternoon.
For you.
Great. Yeah, this is Scott Jacobs. He's a 28-year-old gentleman. This evening he's had a head-on collision with a tree at approximately 35 miles an hour. He was wearing a seatbelt and he self-extricated and was ambulance at the scene. Airbags were deployed. He's obviously intoxicated, so we've secured his C-spine. He's complaining of abdominal pain. He's been trying to remove the collar since we put it on.
I didn't drink anything.
Alright, Scott, his obs are stable, apart from he's tachycardic a bit, and he does have some bruising over his left lower quadrant. No drug allergies, and he's had a gram of paracetamol and 60 milligrams of codeine about 15 minutes ago.
Thank you.
Good
What did you say his name was?
Scott Jacobs, 28.
Doctor,
We'll just start by having a look in his mouth.
Okay,
doctor,
Thank you.
doctor. I haven't had a drink. I haven't had a drink. Alright.
Well, we'll just ask you a few questions
Yeah.
and then do an exam of you, and then we can get to the bottom of what's going on. Is that okay?
It's an accident. Alright.
We're just gonna. We've got the history, haven't we?
Oh,
Scott, can you tell me, do you have any medical conditions?
no,
Okay.
no.
Are you taking any medication?
Just no one again. I'll take paracetamol.
Okay.
No one again.
Taken any today?
No.
Have you taken anything else today? Any recreational drugs?
No.
Okay.
No.
And you haven't been drinking, did you say?
I haven't had a drink.
Okay.
Don't listen to anything what that man said. Alright. I'm not drunk.
Just have a look into your nose.
I only had a couple of drinks.
Thanks, always probably fine.
Yeah. And then.
Could we have some obs with a respirator and question, please?
Oh dear me.
We're just going to have a listen to your chest.
What happened to my car? What's happened to my car?
Just going to check your oxygen levels there, Scott.
What's happened to my car?
Just relax your. Just going to press onto your neck.
Oh, bloody hell.
That's all.
No, yeah.
Respiratory there is
Are you in any pain anywhere? Or can you tell me where the pain is?
Yeah.
And has that only been since the crash?
Yeah.
Okay.
Oh, what's that on my arm?
That's just a little probe on your finger there. Scott, don't worry about it, it's fine. We're just keeping an eye on your breathing.
What are you doing now?
I'm just going to put some leads on your chest so we can just see, keep an eye on your heart rate.
I'm just going to put my hands around your chest.
What's going on with
And
me
can
heart?
you take a breath in and out?
Nothing, we're just observing things. We're just observing.
So that was equal. And then just going to have a listen to your chest.
Oh, dear me. Listen, I can't stay here too long, man, because
Can you take some deep breaths in and out for me?
I told Mickey that I'd
Just for 1 second. Okay. What were you saying?
I told Mickey that I'd be picking him up because he's gonna go to Saltburn, and I said I'd drop him off.
We'll see how you're doing, but I think what's likely is you'll probably have to stay here for a while.
You will? No, man. I'm alright. Look, I just
Exactly.
give us something for this pain and I'll go.
Should we? We're just going to quickly do some more exams and then we can get you some pain relief. Yeah.
Yeah. Hey, shh. I'm alright, you know.
You're alright.
I'm alright.
So the breath sounds it's unclear, but shallow breathing, and then the stats are fine.
Good Lord.
Just hold me a second. I'm just gonna have a listen to your heart.
Maybe we should give him some pain relief now, because his stomach might be hard to examine without.
Listen, no, I don't say this the wrong way, right? But
Yeah.
I need to get this thing off now, right?
If we just keep it on while we finish our exam,
I know, but
just keep it on for us.
I
Keep on
know,
for a little
but
minute.
I don't need it,
I
you
know
know.
you do. It's
I
just,
mean,
it's
that's
just
all
a
right.
precaution.
I know.
I know it probably is. We put
But
it along.
listen, I've got to get going,
Do
you
you mind
know.
just have a, you have to stay here for a little while.
Will you just get your hands off it, man?
Thank you.
And let me go, will you?
We're just going to get you some
What?
pain relief.
Scott,
What?
you're okay. Leave that collar on. It's keeping your neck safe.
Ah,
Yeah.
listen. Hey,
Just go get that. Thank you.
you, where you go?
Yeah.
Bugger this.
No, please leave it on.
Why though?
But we're not sure. We need to assess everything,
Come
make
on,
sure that we
I'm
haven't
all
injured
right.
your neck.
I'm all right, you know.
I think you probably are, but we just need to check.
All right, well, check what?
Because if you have hurt your neck and you start to move it, it'll make it a lot worse.
Will
and
it?
damage it.
Oh, is that like?
Yeah. So if you just leave it on for a little while, just leave it be.
Oh,
No, just leave it be.
oh, fuck it. Get up, man! Just never get up.
We need to keep it on until we do
I
a
just need to get it.
scan.
Can I
of
put
your
it back
neck.
on?
Get
Can I put it back on?
Bloody hell.
I just need to keep it on until we can check your neck.
No, don't want it! On! Leave it up! Right! No, then.
Scott, I know you're in a lot of pain. I'm going to give you some
Ah.
pain relief, and that might
Ah.
help. And maybe
Ah.
we'll keep the collar
Ah.
on, eh?
Oh,
Just to keep you safe.
oh,
Let's pop some meds
oh, I
in
just
this.
want to get out of here. It's driving me up the wall.
Alright, then.
Ah.
Alright.
Ah.
An ABG.
What's this?
She's getting someone to get one.
Oh, is that already?
What's that for?
That is a stethoscope. We're
Is it?
using that to listen to your
It
chest.
is
It just has some strong analgesic pain relief there,
Ah.
Scott. That should
Ah.
help.
And would we be able to
Oh,
see
I,
bloods as well? We need bloods.
Oh, I feel a bit funny.
Yeah, I can do some
How do you feel?
What would you like?
Can
Oh.
we get a
Do you feel okay?
A use needs NFTs, a
What
CK,
did she give me? there?
a
Giving you some pain relief. It's going to help the pain. You might feel a
Alright.
little bit more.
can we is it on
Alright.
the screen? Can you
Yeah,
do that?
could you
On
on
the
the
screen?
screen?
Yeah.
Can I put this back on?
Sure.
Oh, okay.
Junior?
Yeah, both of those. And
Oh,
CRP.
Okay.
Group and save.
what word?
Okay.
Anything else I've missed?
What did you say?
FPCs, CRP, FTs, USNEs, CK, alcohol, drugs. Group and save, yeah.
Hey, I feel really grim now.
Okay, I'll just take some from this arm. I was going to take some bloods from you there,
Hey,
Scott.
you're
Just to
so
check that you're
funny.
okay.
What did you give me there? That was good stuff.
It's some strong pain relief.
What is it?
Are you feeling a bit better?
Oh, your magic.
Oh, that's
Right,
good.
Scott, I need to have a look in your eyes just to check that
Yeah.
everything's okay with your head. You haven't injured
Yeah.
your head.
Just tourniquet
That's
around your
nice.
arm.
So 1 second.
Oh, that's right. It's not. I still gotta go.
I'm going to take some bloods. Sharp scratch coming up there, John. Scott, sorry. John, that's good, isn't it?
And then get a temperature and then glucose once she's done. But is that pan is meant to be?
Ah,
Okay, John, that's brilliant. Scott, that's brilliant, thank you.
I'm going to have a look over here. Is there anything on the mastoid on that side?
Can't
I
see
don't think so.
it.
I think he's alright.
Should we get a
I'll just get him to do his temperature
body
there.
CT
I'm
scan?
going to take your temperature there.
Oh,
Oh,
and
sorry.
just
You sure?
I don't know.
Where we're going from
Just
here.
take your temperature there, John.
We're just going to have a feel of your abdomen.
36.
Hey, normally you need to buy me a drink to do that.
We need to, like, because we need a chest x-ray. And then
Would you just do a chest X-ray and abdominal CT if you think you need one, and a head CT rather than
Listen,
yeah,
listen,
I don't know, like RTA.
Yeah.
I'm alright, you know. Just let me out of
I don't know
here.
if it's with trauma.
Should we just, yeah.
It's quite bruised there, isn't it?
Yeah.
Steady. What are you doing?
You have a ruptured spleen.
Hey, what? No,
Okay. And then,
don't touch, please. No, thank you.
okay.
That's okay.
Thank you.
No.
Um,
God, just get up, man.
and then,
Like
Yeah.
escort.
Blood pressure.
Can I have some more of that stuff?
so could we get 500 milliliters of saline
Okay.
as well?
Are you okay?
Is that start?
yeah.
I don't know,
No.
I feel a bit dizzy, like.
And then, is there bruising anywhere?
Listen, doctor,
Yeah?
I feel a bit dizzy
How about when did you start feeling dizzy?
just now.
Okay. I'm gonna give you some food because your blood pressure's gone down, that might be it.
Is it?
But we're gonna see about getting some
I don't-
scans. I'm
I
gonna
don't
speak to
feel-
a senior.
I don't feel very well. Listen.
In what way?
I just,
Just pop your arm
I don't
down there,
feel-
Scott. Just going to stick this
I don't
fluid
feel
in.
well.
I'm just gonna call the doctor, I'll be back.
Can we get an ultrasound from them as well?
And you need to request
We need to request
Yeah.
that.
But yes, that's a good move. Yeah.
Hi, can I speak to Amy?
In what way are you feeling worse?
Yeah, I'm gonna pass
Hi,
out.
my name's Amy, I'm gonna be asking Charles in recess. I would just like to speak to you about this patient. I've Scott, he's and he's 50, is he in his 50s? And his 50s, and he's coming, he's been in a road accident. Believed to have been
Oh, is it that connection? It's not bridge.
collided with a tree.
To get specialised.
Last per hour. We're concerned he might have a ruptured spleen. And he's also complaining of dizziness. We're not really sure whether to do a head scan. Can you remember he's wearing a seatbelt?
Yes.
Yes. Yes. Was he ejected from the vehicle?
Self-extricated.
No, I don't think he was. I think he got out of it himself. Yes. Paramedics. And it's also on the notes. Paramedics told us that, and it's also on notes that we have here. I don't believe so. Any there were passengers? I don't believe so. No.
Was there any passengers in the car with you?
No.
No passengers. Examination, he has bruising over the left flank, and he's in too much pain. To be examined there, and that's after I believe it's IV morphine. His blood pressure is starting to drop a little bit. We've given him saline, and his pulse is at about 140, and his rest rate is 28. Yeah, and we're also not sure about whether to rule out other injuries. It's quite difficult to examine. How much is it for just pain done by? Can you ask him? I don't think by much. I think it's still.
Has the pain relief helped at all?
Yes, coming back.
Did it help at all at the beginning?
Yes, but it's coming back
Okay.
now. It's
Okay, I think it helped a little
it's
bit, but not
getting
it's
worse.
I don't think it's
getting
worse. Difference in the pain's getting worse. Yeah. Yes. 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 We asked for a blood test, but he didn't put it back yet. We've given 500 mil saline. Has the saline all gone through?
That's practically through now, isn't it?
Could we have another 500 mils, please? Give me another one.
Can we get another blood pressure as well?
Yeah, sure. I don't think we've rechecked blood pressure.
Could you put
recheck
more
blood
fluid
pressure?
up there, Scott?
Just what
Just
you
going to do your blood pressure again, so that cuff's going to go tight.
Okay. Okay. Thank you. Thank you. I need you on the surgical bench. Could you give him some more morphine, some IV paracetamol? Is that okay?
Yeah.
Has his blood pressure come back up?
Into his blood pressure. It's trying again, isn't it? We don't have any of those.
Or it's in tranexamic acid. Hi, can I please speak to the surgical registrar?
That blood
Okay,
pressure.
Scott, just bear with us. Now it's gone tight, isn't it? I think it's struggling to get
I'm
this.
having a situation process with the patient that we're quite worried about and you can see.
If it's not working, could we get a manual blood pressure?
This gentleman's been in a road traffic collision head on with a tree at 35 miles per hour and he's got bruising and left leg pain and the hospital really responded to morphine is getting worse and he's
Looks like his
hypertensive.
blood pressure's staying at 91/68.
Okay.
It's just not reading it on there, but
Yeah.
there's the record.
Okay.
Um,
Do we know
Don't
who
stop
dosed
that.
the drug?
Yes.
Do you know what dose she
I
took?
spoke to Razina but she was not providing
Nitric acid.
Okay, yes, I'll get that sorted for you. Morphine.
Thank you. We'll give some more morphine, some IV paracetamol, some tranexamic acid and antibiotic fluid. That's it, I'm going to wait.
Are you still feeling a bit dizzy?
And we have that image in the archive. Yeah, I think we need to SCT. He, not that we're aware of, but he's complaining of dizziness. We're not sure if he has a head injury, and it's difficult to examine him at the minute. There's just a lot of pain. We think he's still intoxicated. Yes. Okay, I'll get some imaging. I'll get some tea.
Scott, I've got some more pain relief for you. Scott, hello there. It's Andrea. I'm just going to give you some more pain relief.
Do any of your arms or legs hurt?
No.
No.
Just a second.
That was fine. Yes. Yes.
Put up some paracetamol as well.
Thank you.
I'll get the trim.
Do I need to press that and check
No.
with my hands?
as well. We need to request it.
Do we, sorry, do you know, do we request a CT with your teenage first one?
You need to kind of get senior authorization, I think, for CT.
I think I've already spoken to them about getting imaging, but I
Yeah,
don't know
give
whether
them
they
a
need to
give
be
them a
here.
ring. Yeah, we can send the request form for you. Give them
Give radiology.
yeah, set them.
Wait, I'll call Bookman first.
Sorry for being horrible across on the phone. Trying to be more realistic. Not all surgical ladies are like that, but yeah. Okay. What was good? Now from the team first, please.
I think
And I'll ask
dealing with
Ellie.
a difficult patient, etc.
Yeah?
Is that one?
He was a difficult patient, wasn't he? Yeah. What was the good part? How did they deal with him?
The de-escalation part, communicating it.
And I like how you use the stethoscope skills at the early stage.
Before he hits you all with that.
I thought like communication between the two of you was really clear
Yeah?
and like you didn't like panic. It was
Yeah.
nice and like calm.
Yeah? Anything else?
He was a like the A2A structure. It was good.
You got to the diagnosis pretty quickly, didn't you? What was the diagnosis? Okay, yeah. If I say that's diagnosis number 2, what was the first diagnosis? Yeah, that was there. Hypovolemic shock. That was the first problem stemming from the second problem, wasn't it? Yeah? And that's what you started treating first. This you can't treat until you send him for definitive management. Yeah? Okay. What were the challenges? Difficult patient? Yeah? What else? Now, Ellie and Emma can join in. What were the challenges?
I think I was a bit hesitant about getting imaging initially.
Okay. So what can help when you're hesitant in getting something or you can't decide on your own?
Ask the senior.
Discuss amongst yourselves, yeah? Use each.
Sorry for the shouting.
I have to apologize as well for being the bad yeah, so first thing is discuss with the team you've got there, isn't it? Talk to each other. Somebody might be able to give you some idea, they know of some guidelines, something like that, and you've always then got the senior to speak to as well, which is the right answer every time. Yeah? So don't hesitate in thinking you are giving a wrong answer. Okay? As long as it's not a false answer. That's the one that is looked down upon. If you haven't checked something and you say you have checked, that is wrong. But if you think there is something that could potentially be there, even if the diagnosis may be wrong, that's your thought process, that's your rationalizing, okay? Anything else? What else were the challenges?
Always knowing when to give pain relief.
Hmm? What was stopping you from thinking when to give pain relief?
Because sometimes you can't always get like a reliable exam if they've given pain relief.
Yeah, isn't it? And that's such a well-founded belief now that even patients don't take analgesia. When you work in A&E, it will be very common. They'll come with pain going on for several hours without taking analgesia because they think it will mask their pain when you examine them. However, what we say is, if you've got an internal organ injury, yeah, you might not be jumping around in pain, but when you will do an examination of palpation properly, you will get the tenderness there. So it can't take away that sign from there. So give them the analgesia, because what happens is they are tachycardic, they are tachypneic, they are agitated, they'll injure their C-spine, and because of all of this, it will make the hemodynamic instability worse. So it's better to give them the analgesia. What would stop me from giving analgesia would be, or make me stop and think, what should I give? Would be his numbers on the board. So if he's got a blood pressure of 60 systolic, I might hesitate giving morphine at that point of time. I might start with paracetamol at that point of time, IV, and then think, okay, what else can I give him now? Maybe I can give him some fluid to bring up his blood pressure and then give the morphine, so I've got some space to do it. Okay, those are the only things that would stop me from giving the analgesia. Okay, so analgesia is difficult in trauma. There's no doubt about it. Okay. Anything else? Nobody's mentioned the first challenge of the scenario. You said difficult patient, but what was the difficulty in that patient?
Him trying to take off his.
Yeah. So C-spine management in trauma. You won't always get compliant patients who've got their collar on and they'll stay still for you until you rule out C-spine injury. You try to de-escalate. What else could you do? He's adamant. He wants to take it off. He's trying to shrug it off. His neck is moving like that. What do? You try to still put it back on?
Try and like ask them to stay still.
Mm-hmm.
If they're
He says no.
You see, you could say he doesn't have capacity because of the whole
Yeah,
alcohol
he doesn't
stuff,
have
and
capacity
then,
for sure, yeah.
Yeah,
Then what do?
I don't know, restrict, can you do, I don't know.
So if somebody hasn't got capacity and you want to do something against their will, either they are too drowsy to stop you from doing it, then it's easy, isn't it? You just put the collar on. But he's not drowsy, isn't it? He's alert enough and agitated enough to try to pull it, but he's not got capacity. What do you do then? Will you sedate him to put the collar on? No. Will you restrain him to put the collar on?
Do you have to fill out like a form that says like he's gonna endanger himself, and can you put like the mitten things on that you can't grab?
Those are good thoughts. Those are good thoughts, but generally in ED we don't reach that point. We generally have other measures like first restraining, not talking about this patient with a C-spine injury, otherwise patients who are violent, who have had drugs, alcohol, we try with de-escalation communication, we try restraining with the minimal force that is required, and we use sedation as well. With him there is risk of head injury already there. So you don't want to upturn him any further, and alcohol/drugs. So we wouldn't be using sedation, especially for the C-spine collar. What would you do then? I would help him take it off instead of him pulling it off. Why would I do that?
Because then he's gonna stop moving anyway.
Yes. Okay, so the most recent guidelines say that in pediatrics, collar is almost out. Unless you've got a very compliant child who's able to keep still wearing it. Almost every time, every child who's got trauma, put the collar on, their first thing is agitation is secondary due to the collar. It's not a comfortable thing. You try it once by yourself, it's a horrible thing to wear, okay? In people who are agitated, you try de-escalation. If they still don't want the collar, you take the collar off yourself, okay? Because what will happen, they'll calm down and they'll stay still. What have you got still on the sides? You've got the blocks still, isn't it? So the blocks are there, that will serve as a tactile reminder for them to keep their head still. Some people don't even tolerate the blocks as well. Then you've got to again negotiate with them. Because your point is keep your head still. Yeah, I don't want any further neck injury. You use rolled up towels, keep them to their side as a soft reminder. If they still don't want it, okay, in this scenario, I know he's not got capacity, but I can't sedate him to put this C-spine. I'll injure him further because of the head injury. So I'll remove it and I'll only hope and tell him, can you keep your neck still? Okay, just answer in yes or no and don't move your head or neck. Okay, once you saw that actually in the trajectory that you guys were doing, when Andrea gave him the pain relief, he actually then relaxed. And then that was the time when you could have tried again to close the collar, which Andrea then quietly did. It might be that he might have still not tolerated and you say, okay, fine, all right, guys, I'm not doing it. But that's your chance when you do it. So you've got to look for the visual cues in this, okay? So C-spine is best immobilization, collar with blocks, that's called triple immobilization, okay? Not tolerating, just the collar, not tolerating, just the blocks. None of that, manual inline stabilization, okay? What do? It will take a team member away from you. You use the person who's there to hold the patient's head still. Okay? Some people kids do better with manual inline stabilization because there's somebody, because imagine as a child, you're looking up like that. Can't see anyone. People are just doing things on you, to your body. So if somebody is peering over you, talking to you, calming you down like the anesthetist is there, usually we get an ODP with the anesthetist is there in the trauma team that comes. So if this is the head, they're holding it down like that, okay? Thumbs around, not covering the ears, and fingers stabilizing the neck like that, okay? And you're talking and calming them down, telling them that I'm not pressing hard, I'm only holding it in place, and if you feel there's any pain, let me know, I'll remove it away, and you can tell them what's happening now. Somebody's going to give you some pain reliefs, it just calms them down, okay? It will take away a team member for some time. They might agree to the next step, to put on blocks or something like that, or you might have to just keep doing the manual inline, okay? Until you clear the C-spine. How do you clear a C-spine?
X-ray.
X-ray, okay, yeah, X-ray is one modality. So imaging, what comes before imaging?
Isn't it the Canadian C-spine?
Yeah,
Or-
that's to decide what sort of imaging or if you need any imaging or not, yeah? My question is, how would you rule out a C-spine injury before you image? We'll come to see Canadian C-spine to decide what to image or what modality to use. What comes before imaging?
Is that like a
Clinical
history?
examination. Yeah? Firstly, always in C-spine, which comes in the Canadian C-spine is also your history. Somebody who's involved in an RTC, if he was an unrestrained driver going at 35 miles an hour, or his car had rolled over, or he was ejected, higher risk of C-spine injury, yeah? Any RTC gives you higher risk at high speed. So your history itself is telling you immediate onset of neck pain, yeah? If he's telling you he's got numbness or paresthesia, so he's giving you some neurology as well. All these in the history are telling you, I'm worried about the C-spine. What do you do next? You examine next. So examination is, you examine for bony tenderness, okay, spinal and paraspinal. If they're giving you isolated, discrete C-spine tenderness, say C5, C6, I'm worried. I'm not going to take the puzzle off them, yeah, until I image and rule it out. And again, imaging will rule out bony injury, not the ligamentous injury, unless you do an MRI. So you do the tenderness, and then what part of the exam comes next in examination? Is your upper limb neurology, because that's what C-spine is dealing with, isn't it? So first thing is you look at the history, second thing is you palpate the C-spine, look for signs of injury. Third thing is you do all of their upper limb, which is their sensations and their motor. That would be your dorsiflexion, palmar flexion, extension, abduction, adduction, all of that, and see if they've got any dermatomal pattern in there or myotomal problem in there, okay? So if you've got nothing in the history, sinister, no bony tenderness, no upper limb neurology, and then you would progress to then, okay, I've not got any red flags, let me ask him to move his neck now. Okay, this is the stepwise approach. Then you tell him, can you move your neck for me? If he's able to do full degree of neck movement, so lateral flexion to the right, lateral to the left, upwards, extension, flexion. All of it is fine, no C-spine injury, no imaging is required. Okay? If you've got signs at the history stage or examination stage, you don't ask them to move their neck. You keep them immobilized until you do the imaging. If the imaging is positive for a C-spine injury, you do spinal referral and they'll tell you what to do. If imaging is negative and you had red flags here, then you reassess, examine again with tenderness, neurology, and range of movement. Okay, so you can't move a neck if you've got red flags up there. Okay, we've got to do a stepwise approach. Okay, so the first thing in trauma, which I think I might have done with you guys before, I'm not too sure now, was you guys did A, B, C, D, E, but it's C, C, A, B, C, D, E. The first C is what in trauma?
C's one.
Before that. Good, that's the second one. What's the first one that would be you before the C spine?
Collateral history.
No, before that. What do you think, Emma? I thought you looked for it. Might have been mistaken, but I thought you looked for it. Did you look around for any bleeding? On the bed? No? I thought probably you were doing that. So the first thing is catastrophic hemorrhage. So as soon as the patient is wheeled in, your first step is to look around. Is there any bleeding on the bed? Or are they bleeding arterially from anywhere like the limbs or stuff? Because you've got to do that. If he's got an arterial spurt from his leg coming out, the first thing you'll do is put a pressure dressing, put a tourniquet on, try to stop that bleed because he's going to hose out from there before you do any of the ABCDE assessment. Okay? Second thing is maintain your manual inline stabilization or stabilize the C-spine by the mechanisms which we mentioned above. Then you come to your ABCDE. In real life, everything happens simultaneously. Doesn't mean that you ignore the 8 and then if it's got stridor and you're trying to do that, you've got people that you can delegate for that. Okay? Then you mentioned about history, isn't it? There was a point where you were confused between should I start examination or should I do history? What should you do in trauma? He looked stable initially, didn't he? So you had time to take a quick history. You had quite a good history of the RTC already. So the E bit was almost covered. A, allergies. M, meds. P, past medical history, which you did ask about. Last, ate or drank, which you didn't ask about, which may be useful later. And then RTC mechanism. What's important in that is to ask about the passengers in the car. Did he self-extricate or not? Any airbags deployed or not? All the questions that I asked you over the phone, yeah? And if you don't know, don't say I think so, yeah? You have to go and confirm with the patient, or if you can't confirm, say, I'm not sure. We'll have to check or find out collateral history from paramedics. Because if you say, I don't think there were any passengers in the, whereas somebody had died on the spot, that's a huge difference in the risk of that RTC versus what I am being told, yeah? Okay, so ample history is what you do immediately when the patient comes, and then you do your CC, A, B, C, D, E. Bloods wise in C, you did A, I saw you guys did it properly. You did B. Did you expose him to check the chest? No, okay. That's why in primary survey, that's called, have you heard of the term primary survey and secondary survey in trauma? Yeah, okay. So in primary survey, your aim is to rule out life-threatening problems. Life-threatening number one is obviously any airway problem. So anything in the neck, if you see neck swelling, if you see there are airway problems, that's there. In B, until you expose the chest in trauma, you cannot rule out just by listening to the chest. Okay? What are the life-threatening ones? Flail chest, where you've got multiple rib fractures and the chest wall is moving paradoxically. Okay? That needs intubation and ventilation. You can't maintain it on your own, and significant analgesia. Pneumothorax, especially tension pneumothorax, which you need to do needle decompression immediately. Massive hemothorax. And airway injury in the sense of tracheobronchial injury. Okay? In C, as part when you've exposed the patient, if you see bruising, say he didn't wear a seat belt and there were no airbags deployed, his chest hit the steering wheel. You might see patients who are otherwise completely no other signs of injury, but they're hemodynamically unstable because they've got a cardiac tamponade. Okay? So blunt injury to the chest wall, you have to rule this out. So cardiac tamponade. That's why when you listen to the heart sounds, you'll hear muffled heart sound, see neck veins, that would point to an hemodynamic instability. And also mediastinal widening. What are the structures passing through the mediastinum? We talked about the airway, so tracheobronchial, the trachea is passing. What else goes through the mediastinum? What's in the middle of your body? Aorta, number one, good. So aortic rupture or dissection. Anything else?
Esophagus.
Esophagus. So esophageal ruptures. So you've got to think of these structures when you're doing that in the primary survey. D, obviously you're looking for a head injury, which is a major head injury. So you've got signs of battle sign, panda eyes, hemotympanum, you've got blood coming out of the nose, they've got decreased GCS, and they've got focal neurology. So your D assessment cannot just be pupils, GCS and BM. There's always a fourth component, which is focal neurology. How do you check focal neurology quickly? Don't do a full neuro exam. Focal neurology is he moving all four limbs equally and symmetrically? That's all you need to do. And if he's not got one side moving, you automatically know that there might be a bleed on the other side. Okay? E-wise, which in trauma we can continue as C, because I saw you guys were thinking, should we do it in C or should we do it in E? And I like it doing in C because it gives me a picture with the obs at that time. So what's in E in trauma? You need full exposure in trauma. So E part is in primary survey, you've got to check the abdomen. So liver, splenic laceration, pancreas, need to feel the renal angles at the back for kidney injuries. And another important area is the pelvis, which nobody checked. Okay, got to feel the stability of the pelvis from the outside. You've got to look in the groin to look for perineal bruising, blood at the urethral meatus, because what does that point towards? Urethral injury or bladder injuries. Okay, so if you are otherwise catheterizing without looking at that, it's going to be massive disaster, and you can bleed out a lot from there. So check the pelvis and the groin. And what's the last bit in E? In primary survey is your long bones. Okay, that's part of primary survey. And you asked an intoxicated man if he had pain anywhere. And he said no. He was intoxicated and he had morphine given. Do you think you would trust his judgment? No. Okay. So how do you assess? You've got to press and check, and you've got to expose. So if you've got a swollen thigh that is tender on your examination, you know there might be a potential femoral fracture there. Okay. If he's got a femoral fracture, is he going to tell you his neck is hurting? He's got a distracting injury. Plus he's got alcohol or drugs on board. So you've got to take everything with a pinch of salt with that. Okay? So that's E. So that's your primary survey. These are the life-threatening injuries you need to rule out. Once primary survey is done, you do the imaging, patient has been stabilized and resuscitated, then you do the secondary survey. Secondary survey means press every tiny inch of their body and do a full A, B, C, D, E again to see if they've missed a little tiny scaphoid fracture or something like that. Okay? What bloods are specific for trauma? The bloods you asked for were MBC, USNEs, LFTs, CK, I was very happy, CRP, alcohol, drugs, and group and safe. What did you miss? Yeah. So VBG, very important. Blood gas in trauma because of the lactate. And number 2 is that calcium. I told you about this before as well, isn't it? Calcium is very important for the coagulation, and in trauma, coagulation gets impaired and the coagulation factors are eaten up. So if you're hypocalcemic, in trauma, you're supposed to give IV calcium to replace it because you don't want the coagulation to be impaired. So you did an ABCDE assessment, okay? You found that there's potential head injury and potential neck injury, okay? Because significant mechanism and he is obtunded with the alcohol and the drugs you've given him or other drugs as well, and you can't safely rule out a C-spine injury. So you've got to think head and neck together, and you've got an abdominal injury. So what scan are you going to do then? Let's assume you did the pelvis, groin and long bones, everything was fine.
CT.
Yeah, good, CT. What part of the body?
fast scan as well?
Yeah, we'll come to fast as well. If I say CT is the answer, what CT scan are you going to do?
Head, neck, chest, and abdomen.
So head, neck, chest and abdo. Okay, so we're skipping pelvis then.
Did we not say pelvis was fine? Just then?
Yeah, it was fine, yeah.
Don't you in trauma you just do it full?
So not all traumas require full body, yeah. If there's a specific focus because somebody was going on a bike and there's a handlebar injury and he's only got abdominal injury, don't need to do head, neck and chest. If he's not intoxicated, he can tell you completely, you've ruled it out. But in this patient, you're worried about the head, you're worried about the neck, you're worried about the abdomen. You've got to scan the bit in the middle. If something's injured this and this, it's highly likely there will be something else injured in the middle. So as per the protocol, if you're imaging one part and the part underneath, you've got to image the middle part as well. So this, don't skip the chest, you've got to do that with the abdomen, and pelvis comes with the abdomen altogether. Okay? So abdo-pelvis is going to be with contrast, without contrast? Without contrast. Okay? Who says without contrast, who says with contrast? And why? What's the biggest thing you're looking for in trauma? Blood. So what do you use to detect blood? Contrast. Okay. So if you remember from my first talk from the AKI or something like that, I had mentioned about the CT. Whenever you need to detect blood, it has to be contrast CT. Okay, because you want to you have to check for retroperitoneal bleed in this with this kidneys being retroperitoneal organs. You've got to check for that. You've got to look for the aorta extravasating contrast from there. So blood is the major thing you need to rule out. Okay, if it was just CT head, you could have done it non-contrast. Okay,
Why is that different?
because in brain the blood shows up in the grey matter.
Okay.
Whereas in the blood vessel, say in the aorta, if you want to detect a tiny leak that's happening, extravasating, need to give the contrast and see if it's leaking out from it. Okay, it might have not have pooled already by that point of time. Okay, that's a closed space, so let's go quickly. So CT contrast, pan scan, what we call trauma scan. What is the other thing? Before imaging to resuscitate this patient you would do, you've decided about imaging, you've contacted the senior, you've contacted the surgical reg, or even before that. Trauma, number one, if you suspect bleeding. Now we're coming to that was trauma assessment, trauma management. Number one trauma management after your bloods is, if you are suspecting bleeding, significant bleeding where he's shocked with trauma, you need to activate the major hemorrhage protocol. Okay? And once you're activating that, this comes hand in hand with that. 1 gram tranexamic acid stat, followed by another gram infusion over 8 hours. But this has to be started. Even if you leave that, no problem. This has to be started when you think of major hemorrhage protocol. The moment you're thinking group and safe cross match, your brain should say, do I need just a cross match and I can wait an hour for the blood to come back? Or do I need to activate major hemorrhage protocol? Always question immediately. And then your brain will tell you, okay, splenic rupture, I'm worried, he's not responding to the fluid I have given. Okay? So you need to replace blood with blood. If major hemorrhage protocol, why do you want this rather than just blood? Because you will get RBCs, you'll get FFPs. In the second lot, you'll start getting cryo as well in it. Sorry, platelets first, and then in the third lot, you'll start getting cryoprecipitate as well. Okay? So you get all these factors, not just the RBCs that you get with O negative blood or cross-matched blood. And because in trauma all of these get used up, you need all these factors as well. So major hemorrhage protocol activation. If you think patient has stabilized, you can stand it down, no problem. But activation, thinking about it is important. So major hemorrhage protocol, run tranexamic acid, analgesia, make sure the patient doesn't get hypothermic, contact the senior, contact the registrar and the surgical registrar. Okay? Don't forget these 2 things. Okay? Yeah? Any questions? No? Okay. I think we've got the last one of the day. Who's ready to do it now? Nobody. Come on, good practice. You're not being marked for it. I know it's daunting doing it in front of your peers, but by now you must be used to it. Come on, good practice. Decide amongst yourselves. I'll not choose. But you have like probably 30 seconds to decide.